Well, we're very lucky to have with us today Lynne Maher, who is the Clinical Director for Innovation and Improvement in the health system around Auckland, New Zealand. Awatea, but I'm not sure I'm pronouncing that well. Lynne, thanks so much for talking with us. We had the pleasure of your insights from quite a while back now when you were still in the UK, working in our National Health Service. But again, you were heavily involved with this whole challenge of innovation and improvement. I wonder if we could begin with you explaining a little about the context you're working in and the role you're playing, the role of innovation in the healthcare system.
Yeah, thank you, John. And I'm delighted to be able to talk to you and others again, because, of course, I love innovation and think it's particularly useful in healthcare. So my role in the beautiful city of Auckland here in New Zealand is within an innovation and improvement unit called Awatea. And Awatea was a name gifted to the unit by our Maher population, the indigenous nation of New Zealand. And it means dawning of the first light, which they thought was, and we think is particularly helpful in terms of setting the scene for Awatea being the innovation unit. We particularly work across our community, which is in Auckland and South Auckland, but also we link in, with people from around New Zealand and the world. New Zealand's a really interesting country because we have just about 5 million people here. So you tend to know people, or, they say there's, sort of only 2 degrees of separation here. So you know what people are doing, you know what's happening, you know what they're thinking of working on. You can just phone them and say, well, I've heard this, what are you doing? So actually it's a good place to be in terms of innovation. And in health, there is a focus on innovation. We know that we've got to get better for us, for the consumers, the patients, the family, and, for the fiscal system. Helps
Thank you for that. And I'm delighted to hear that you're still as involved as ever and as passionate as ever about innovation in healthcare. But I wonder if you could also then explain to us where you see some of the big challenges.
Innovation is one of those terms. There's a few terms that we use glibly. And we think everybody is thinking, when I utter the word innovation, I have to stop myself and think, well, do people understand the same as me when I'm talking about innovation? So that's one of the things. It gets used all the time and people don't really often know what it is, and less so know how to do it. And it's one of the questions that I get asked a lot. They say, well, how do I do innovation? Okay, let's go back a bit then. So, I actually think that's a big challenge. I think the other challenge is people think they can't. People don't think that they have good ideas. There's gurus of innovation, and generally people think they're special people, and I can't possibly, do what they've done, and it's that belief and the culture in the organisation as well that, should be saying every one of you has great ideas. And actually, many of you don't tell us what their ideas are. Yeah, and helping people to realise that it's normal for lots of ideas to come through, but only some of them to be taken forward. So, if your idea doesn't get taken forward, it doesn't mean it's not a good idea. It just means it's not going to work right now in this context. But, in 5 years, that might be the idea. So there's something around the terminology, the belief, and the culture around it for me that sometimes creates barriers.
Thanks very much. That really makes that challenge very clear. But it also exposes another one, which is Who are we innovating for in the health sector? Because this is one of those worlds where there are many different players, in particular the front line, the clinicians, the nurses, the porters, the others. They're very much a part of the system, but so too are the patients. And one of the big challenges that I know you're very passionate about is this whole question of how we bring users into the equation, particularly how we build on the patient experience.
Yeah, of course I can. It's my number one favourite subject. And, just going back to what I said before in terms of the notion of the lone genius sitting in a shed somewhere coming up with the most wonderful things, there are those people, and they are, I think they're few and far between, and they're very special. They've got very great thinking. But that's not normally how innovation happens. Of course it happens, but I think there's, for those of us who don't have that kind of brain, we have different kind of brains, what's important to recognise is innovation or creativity that leads to innovation is often best with groups of people, because we come from different perspectives, and we can have lots of different ideas. It can be quite difficult for a lone person to have lots of ideas, and you have to have lots of ideas for some of them to be useful. Some aren't. So, when I think about health, we traditionally have focused on just the thoughts and ideas and perceptions of staff as key stakeholders. And that's the whole range from clinicians, administrative, policy staff. But we've missed out on a huge expertise. Those people who are in our system every day, they have lived experience of our system. They've got really great understanding about what works well, what doesn't work so well, and actually what would make it better from their perspective. We as staff members can never have that expertise in the same way. Now, one of the challenges people often throw at me is saying, well, staff members are patients too. Absolutely. And they are really helpful. I would always include staff members who've been patients in a service that I might be looking at or working with. But we have to think again, they have a different perspective because they've got learned experience of that service or practice. So they understand more about what is about to happen, what should happen, what the different roles are, and the language, to somebody who doesn't have that learned expertise. And people, patients who don't have that learned expertise have a completely different experience than staff members. I mean, I often say sometimes staff members are more confident about coming in, or having any healthcare service, and sometimes they're less confident because they know acutely the risks that could be associated, more so than people with lived experience. But if we don't work with patients and families, we are missing out in valuable experience. We're also missing out in different perspectives of ideas, because of course the patients who come to us, work in the steel mill, they're engineers, they're teachers, they're lawyers, they're the lollipop person who helps children cross the road. They've got massive expertise from their own industries, their own families, and their own communities to bring, as well as their lived experience. So, for me, we get double. I mean, I've worked with many engineers, many project managers who are saying, well, Lynne, you should do it like this. And I think, yeah. And I would never have thought that way, because that's, I don't have that expertise. So, for me, it's about bringing as many people in who have the expertise and understanding to be able to bring ideas in so that we have lots of ideas that we can take forward.
Could you perhaps give us a few examples of successful innovation in this healthcare space?
Yes, and it's interesting interesting, John. There's lots of innovations in technologies, which of course we need and we're having more of. But, you know, I also think there's this notion that is sometimes called social innovation. And it's more about working with communities or people in different ways in services and what we call in healthcare models of care. You know, how I travel through my diabetes care. And I think there's many. One that we get great learning from, and we're still in the creativity stage of this piece of work, but we're working with people who live in our community who have diabetes. And for whatever reason, their diabetes is not very well controlled. And we're very fortunate in the area that I live and work that we've got lots of different cultures, and particularly the Maori culture and the Pacific Island culture. They're often people who sometimes struggle with their health and care. And so, you know, and they don't access health and care. They're not able to access health and care in the same way as others. So, you know, talking to them, sitting down in groups, they prefer conversation. Maoris call it hui. So we're going to have a hui with you. We're just going to sit and chat to talk to them about, you know, what's it like for them with their diabetes? How are they managing with their families and their work and other things? And how do they feel about coming into health and care? And, you know, we've had some great insights. So, well, you know, it's hard. Our traditional diet is not the same as we might need in diabetes. You know, I'm needing to feed I work, I need to feed the children. I've got my mother at home that I'm who I look after. You keep sending me appointments at 9:30 in the morning. I keep saying I can't get to those appointments, but you don't listen, so I don't come. So my diabetes goes out of control. And, you know, the insights into somebody's situation helps us with some really easy fixes in a way. Well, of course, we can flag on that person's records that 9:30 is a bad time for that person to be able to come, number one, and also thinking more about electronic methods. You know, for some with long-term conditions, a telephone call would be good in checkup. And it's made us think differently about that, and we're implementing a number of those things right now. Now, interesting for the Maori and Pacific people, they're very clear in their conversations. They say, yes, telephone calls and sometimes Zooms will work for us, but not for the first appointment, because relationships are critical to them. And I can't do a virtual or any virtual appointment for the first time. I've got to eyeball the person. I've got to be in the room. I've got to, you know, understand them. They've got to introduce themselves to me because they're impacting on my life. You know, it's that important. So while, you know, that's not like sending a rocket to the moon in some ways, it is in other ways, because if we can help people who need healthcare access it in a way that's convenient to them, then they are going to access it. They're going to have a healthier life. Their family will have a healthier life. And actually, there's massive benefits to the system. We don't have do not attends and cancellations, which cost us money and time. So, you know, I always think about it. What's the benefits to the person? What's the benefits to the staff? Staff don't like it when there's DNAs, you know, just sitting around waiting for people, and it's bad for the system. So what's good for the person, what's good for the staff, and what's good for the system. So, you know, that's really important. We've also just had a rebuild of a mental health and addictions inpatient unit, because our previous inpatient unit was not fit for humans. And, you know, that's an extensive 5-year process. It is being heralded as one of the most forward-thinking inpatient units in the Southern mental health and addictions in the Southern Hemisphere. And that's because it was designed of course, with engineers and, you know, those engineering designers, but it was designed by the people. And they were very clear about what was important in terms of light, colour, wanting an internal courtyard where they could go out but still be safe within the confines of this place that they wanted to come safe. The cultural elements were really important in terms of coming in, welcoming. And one of the things that was pivotal is the main corridors in the building. They very specifically said they needed to be wider than was planned by the builders, because when they're anxious, actually many people don't like passing people closely in a corridor because they just want to focus on their own health, and it felt enclosing. And so, you know, it does not seem very innovative, widening corridors, but it's made a difference. The whole ideas from the patients have made a massive difference in that unit. And you know, patients who come in regularly and their family just say it is amazing. They're no longer fearful in coming in. They feel calmer as soon as they get there. You know, and the staff are saying, gosh, the environment has absolutely impacted on the whole of our working lives. You know, so there's lots of different ways that people can get involved, and we're working with people now to enable people to leave hospital earlier with cardiac failure. They would normally leave hospital and have to have their drugs titrated to get the proper dose to maximise their heart function, and they would come to the outpatient clinic regularly for blood pressure and weight and the drug titration. So we're working currently, we're on our second trial, working with people so that they get discharged directly home, and all of their titration is done remotely. We teach them how to we send them home with an automatic blood pressure machine and accurate weighing scales. We teach them how to do the measurements, how to record the measurements, and then they get a phone call and they have a discussion with the person. So again, now that's you know, revolutionized care for those people, because no longer do them or their family member have to bring them into clinic once a week. They have more control. They're enjoying taking their blood pressure. We think the blood pressure recordings are more accurate than when they came into the clinic, and they're managing the titration, and actually the results, the stabilization of their cardiac function is better than when they were coming into the clinic. That makes a difference.
Yes, that's made it very clear how powerful the user experience can be in innovation. But it does raise the question, how do we hear their voices? How do we help them articulate their ideas? I know you're a fan of design thinking, but what tools might be helpful in this context?
I think it's fascinating because, to be honest, I am a fan of design thinking, and you know, I call the practice that we do co-design, which is part of design thinking. But it is a process, and an important part of the process is thinking about who the people are, where they are, and how is best to interact with them. You know, I mentioned our Maori population. They much prefer what they call kororo, which is talking. So bringing people together in a hui to talk. That's very, very important to them. They don't like surveys. They think it's impersonal. So, you know, we need to work with them. We need to think about how we can interact with them and explain things in a very simple way, because we use ridiculous jargon in health, and even in, you know, improvement and co-design, it has its jargon. I never say, oh, you know, we want to co-design this, do you want to come and do that? No, I say, you know, we really want to understand what you think it's like going through this process. Can you talk to us about that? Tell us what's not good about it. Tell us what's good about it. And asking them both makes them feel comfortable, because we're not asking them to complain. We're asking them to tell their story, and we're gathering their ideas at the same time. And so, you know, there's that initial engagement is really, really important, and it has to be authentic. And people have got to recognise, especially in health, that whatever they say or do, or whether they agree to a conversation, or, you know, however we'll capture their experience, it's not going to impact on their care. We're very clear about that. And, you know, basically we try to match here in New Zealand, we try and match culture with culture. So with a Pacific population, we have Pacific staff who can talk in the language, even if, you know, people speak English. There's a comfort and safety in using their language. You know, Maori, we have an Indian Asian and a Chinese Asian population, as well as the Kiwis or white Europeans. So we match people for safety. That's really important. And we think about how they're going to feel able to share their experiences. And sometimes it's verbalizing it. Sometimes they would prefer a survey. Sometimes with youth, we do like a hackathon, or we get them to just use their devices and send their thoughts and send images, which is what they do, you know, what they're comfortable with. With children, younger children, they like drawing. We'll get them to draw. We work with play specialists or people at school and get them to draw. So, you know, in design thinking, it is about how we can interact, or co-design. How can we interact? How can we enable people to share things that give us insight into what the experience is, you know, what happens, how does it happen, and how does it make them feel? That, you know, quite often in standard improvement, we look at what happens and how it happens, and, you know, time, spaces, and how many people are involved. But I think when you're working with people in co-design, it's the missing link that you get through co-design is, how does that make you feel? By understanding the experiences and the level of positivity or negativity there, we get a really clear picture of what's happening. You know, they'll use words and say, oh yeah, I went to the GP and, you know, the receptionist was smiling and said, good morning, Lynne. And that just made me feel really welcome. Whereas if, you know, you go into the GP and the receptionist is not smiling and didn't look up, well, that gives you a different experience. You know, they said good morning in my language. I recognized that, you know, made me feel good. So the experience is critical. And actually it's a very, you know, health is scientific and experiences are thought to be quite subjective, but you know what, you can count them. You know, if we're working with 20 people going into that GP practice and we ask them to share their experiences, if 17 provide a positive word for when they meet the receptionist, we can count that and we can graph it at every different point of the journey. And so, you know, it's really good data. Really good.
Perhaps we could move on to another important question. Innovation is difficult to do, but perhaps even more so in the kind of context that healthcare represents. Like much of the public sector, it's got a concern about taking risks. It's a culture where you have to be very careful. It's not simply balancing risk and reward in the way the commercial sector does. So I wonder if you could comment a little on how difficult it is, the challenges in working in this kind of an institutional context for innovation.
Yeah, and it's one of those really interesting things, because I think in many healthcare organisations there is a risk aversity. You know, people think innovation's risky. And so the appetite, they think it's risky and costly. And so the appetite is often not there, and we're often more focused in, well, let's just do a bit better. Let's just get a bit faster. Let's just, do these things. And, I can understand that, throughout the whole systems, there's pressures. And most health systems have fiscal pressures that are really indicating that we have to do more with less. And that's where our thinking has to be. And that's fine. It's good to have a specific challenge, actually, because you think about it. However, this risk aversity, I think, is a falsehood. When I'm talking to leaders, and they say to me, that might be a bit risky. And if we talk to patients, they're going to want things that we can't deliver. I was saying, well, what do you think that's going to be? Well, I don't know, but they will. And that is just not true. It really isn't. Actually, what patients want is the relational aspects. I want people to treat me like a person. I want to understand. I want to be involved into the level that I can cope with. They're not saying, can you put 74 MRIs in so I can have one a week if I want one? It's just ridiculous. The other thing is that it's this notion of risk, because I say to leaders, well, what's the risk of the current system? We've got, we might make some mistakes. We've got high level of do not attends. That's risky because our population are not able to come in, and they're getting sicker, and they're going to come through ED, be sicker. They're going to cost us more, and they might die. I mean, hopefully it doesn't get like that. But what's the risk of the current system, and how costly is the current system or process, and how happy is the current workforce? Because looking at it from a system view, actually staff, if they're not enjoying their work, you tend to get a higher turnover. It's costly to recruit and train staff all the time. So, from a systems point of view, I think there's a really great argument for innovation. And the other thing is, innovation is not something, and again, I think people think about innovation, somebody sitting in a room and coming up with an idea and it's going to cost $1 million. Well, when we're identifying ideas, there's a process about how we select the most appropriate ideas for our situation and context. And part of that context and situation might be, actually, they can't cost more than this, or these ideas have got to be cost neutral or save us money. That's fine. We put rules around that. And when we're testing them, we use small scale safe testing. We've got to have innovation in health. We have new gadgets and new equipment all the time. That comes in. If we're changing systems and processes, that can come in as well with safe testing. And I think when you talk to leaders around that, you see a little light bulb going on. And I think, everybody's so busy. We're just not thinking. We're not stopping to think. When I have those conversations, people kind of look at me and they go, okay, go and do it. Because I don't think there's a rational argument against those, to be honest.
Now, you've already achieved a great deal in the world of innovation, but just for a moment, imagine I'm the Christmas fairy and I can grant you 3 wishes. What would you wish for in things that might help make innovation more effective, make it happen more easily in the healthcare sector?
Yeah, I would wish that somebody's waving a magic wand so that everybody, innovation or creativity thinking, working in a creative way to lead to innovation is in every single person's role description. Because I think, it's not there, so we don't think about it. So I think that's number 1. I actually think number 2 would be, let's help people be confident and capable. because the word frightens people. And again, when I break that down to leaders, I talk about the systems, and thinking about risk in a different way. When I'm working with frontline staff who go, I haven't got any creative ideas, and I start playing around with some things. Well, how would NASA do this, or how would somebody else do this, and bring patients in? What industry do you come from, and how would that be done? The staff go, oh yeah, and I can have ideas. So I think the capability building to enable staff to feel confident in doing this, they will do it more in their, everyday work. They will think about it. So they're the number two. And I think the third one for me has to be to make enable staff, senior leaders, frontline, everybody, to feel more comfortable in recognising the value and expertise of those people who've got lived experience. They're really, really important in innovation because they have ideas that we can never, ever have. They give us insights that we will never, ever have without them. And if we don't have them, we're not going to achieve the most that we can ever achieve. So big wishes.
Well, can't make any promises, but we'll do our best to grant them. But perhaps I could conclude by asking you one more question. A lot of this site has to do with helping people understand the skills and capabilities around effective innovation management. So if I were to ask you, as someone with a great deal of experience in working in this tricky sector, what advice you might give, perhaps what pearls of wisdom could you share with a young, aspiring innovation manager? Any thoughts?
Yeah. Well, number one is congratulations for even, starting in that way, because I didn't. I started as a nurse, so innovation was something that I grew into. So we need lots of young innovation managers. And I think really it's, for me, when I first got into it, it was about immerse yourself in it. Really look to see how people are doing it, who's doing it, and all the different types of innovation, because I think then you will sort of link yourself to a niche. It might be more technology, it might be more social. I call what I do more social innovation. I'm not interested in gadgets particularly, that they come. But then that's where your passion lies. So look to see where your passion really lies, and then kind of really explore that world. Who's doing what? And John, you're gonna blush now, because then you get inspiration from people, and people who are watching. When I found John, it was like, oh my gosh. And John and I have known each other now. I mean, we've interacted 12 years or something, even longer, and it's about get like-minded brains. His are obviously larger, but I learn from individuals, and think about where your role is going to be and what kind of industry that you want to be in. And I think there's some thought process, but if you can attach yourself to people like I have to John, and there's another gentleman in the United States called Paul Plesick, who John knows, and you attach yourself to people and just start bringing your networks together. I think relationships and networks are really important, and if I got one thing to say, it was build relationships and networks with people, because people in innovation are like-minded, and you get connections, and then you learn, and then you get jobs. I came to New Zealand because of the connection, and I might not have been here otherwise, and I'm in a very fortunate place, but do that. Know where your niche is, what really makes you passionate, because that gives you resilience. Connect with people and keep them as close relationships.